picture this. You are a medical student, or maybe a junior physician, right?
Right.
And it's like 2 weeks into your emergency department rotation. It is 2 a.m.
Oh, the classic 2 a.m. shift.
Exactly. The fluorescent lights are just harsh, the telemetry monitors are constantly alarming in the background, and the charge nurse hands you a chart.
Yeah.
A patient is in triage, she is in her first trimester of pregnancy, and she is bleeding.
Which, I mean, that specific scenario is going to be a daily reality in your clinical practice.
It really is.
Yeah, the sources we're working from today and emphasize this staggering statistic, actually. Bleeding in early pregnancy occurs in roughly 10 to 20% of all early pregnancies.
Wow, up to 20%.
Yeah, up to 20. So you are going to see this presentation so frequently that the initial, adrenaline spike will eventually just wear off.
Right, which is exactly when cognitive errors happen.
Exactly.
Because hidden within that massive 20% demographic are these catastrophic, life-threatening emergencies.
Absolutely.
So the mission of this deep dive is to equip you with a foolproof, logically impenetrable framework.
Yeah, a mental algorithm.
Exactly. We are taking the source material and building this algorithm so you can triage, diagnose, and manage first trimester bleeding without hesitation.
Right.
Basically, treat this presentation like a classic locked room mystery,
I like that analogy.
Yeah, you have a very specific, limited set of clinical clues. The patient's pain profile, the volume of bleeding, the physical status of the cervical ooze, and you're operating on a strict time frame.
And time frame is the critical variable here. It dictates your entire clinical posture.
Right.
So the sources define early pregnancy typically as the first trimester, pushing up to the 12 to 14-week mark.
Okay.
But they also make a broader, highly consequential point about the fetal period up to 24 weeks.
Right, because before that 24-week threshold, the clinical focus is overwhelmingly, almost exclusively on the mother.
Exactly. The physiological reality is that before 24 weeks, the fetus just isn't viable outside the uterus.
Right.
So our primary medical interventions, they can't be fetal resuscitation. They have to be designed to save the mother's life and preserve her pelvic anatomy for future fertility.
Which means maternal hemodynamics drive every single decision you make at that bedside.
Every single one. Which brings us to the fundamental principle of emergency medicine.
The ABCs.
The ABCs. Before you even think about an esoteric diagnostic workup, you assess hemodynamic stability, airway, breathing, circulation.
Right. You do not bring a transvaginal ultrasound probe to the bedside of a crashing patient to go looking for a gestational sac.
No, absolutely not. You secure their life first.
So you're looking for the objective markers of shock. You assess the patient's perfusion status.
Yeah, are they pale? Are they diaphoretic, clammy?
Right. You check the radial pulse for tachycardia.
Yeah.
That indicates the heart is pumping frantically to compensate for volume loss or vasodilation.
And you check the blood pressure for hypotension, which is a late and very dangerous sign that compensatory mechanisms are failing.
Well, and the sources highlight a really specific, unique form of shock that you have to recognize immediately in these patients.
Right, cervical shock.
Cervical shock. This is not hypovolemic shock from massive bleeding, even though it looks identical clinically.
Yeah, it's exactly the same.
But it's actually a profound vasovagal response triggered by products of conception POC becoming physically wedged within the cervical canal.
The pathophysiology here is fascinating, honestly.
It really is.
So the cervix is densely innervated by parasympathetic fibers, specifically vagal nerve endings.
Right.
During an incomplete miscarriage, the uterus contracts forcefully to expel tissue. And if a solid mass of that tissue gets caught in the external os, it continuously stretches and irritates those vagal receptors.
And that results in a massive parasympathetic discharge, which acts like an emergency brake on the cardiovascular system.
Exactly.
Yeah.
You see sudden, profound bradycardia. The peripheral vasculature dilates completely, tanking the systemic vascular resistance.
Which in turn causes the blood pressure to just plummet.
Right. So the patient will appear to be in the end stages of hemorrhagic shock. They're pale, altered, hypotensive.
Even if the actual volume of vaginal bleeding is minimal.
Exactly. But the clinical intervention here is one of the most immediate mechanical fixes in all of medicine.
Right, you don't wait for fluid boluses to work because volume isn't the primary issue.
No. You place a speculum, take a pair of sponge forceps, and physically remove the tissue trapped in the cervical os.
You just pull it out.
You just pull it out. And by removing that mechanical distension, you immediately remove the vagal stimulus.
The bradycardia resolves, the vascular tone returns, and the patient's hemodynamics often just normalize within minutes.
It's incredible to see. But it is a vital distinction to make at the bedside.
Right, though it doesn't negate the need for a standardized resuscitation protocol if the patient remains unstable.
No, of course not. If the patient is genuinely unstable, regardless of why they're in shock, the immediate actions are rigid.
You apply high-flow oxygen.
Yes. You establish 2 large-bore intravenous lines and start aggressive fluid resuscitation.
And the sources also dictate giving an oxytocic agent, like ergometrine, right?
Right, to force the uterine smooth muscle to clamp down and physically constrict those bleeding spiral arteries.
Concurrently, you mandate an urgent referral to the gynecological surgical team.
Always. You are essentially temporizing a surgical emergency until the patient can be moved to the OR.
You never attempt to manage an unstable, hemorrhaging patient all by yourself.
Never.
Okay, so let's pivot to the scenario where the patient is hemodynamically stable or you've successfully resuscitated them.
Right. The acute crisis is managed, the vitals are plateauing, and your diagnostic algorithm initiates.
The sources segment the differential diagnosis into a hierarchy, starting with what we're going to call the big 3.
The big 3. And the undisputed apex of this can't-miss hierarchy is the ectopic pregnancy.
The ectopic pregnancy. By definition, this is the implantation of the blastocyst anywhere outside the endometrial cavity of the uterus.
Right. Because the myometrium of the uterus is uniquely evolved to hypertrophy and distend to accommodate a term fetus.
Right, it's meant to stretch.
Exactly. Extrauterine tissues possess zero capacity for this kind of dramatic expansion.
Which makes ectopic implantation a structural ticking clock.
It really does. And the overwhelming majority of these rogue implantations occur within the fallopian tube.
Now, the sources specify that the ampulla, which is the wider, more distal segment of the tube, is the most common anatomical site for implantation.
Yeah, that's the most common spot. But the most lethal site, the location most prone to catastrophic rupture, is the isthmus.
The isthmus. And the structural logic here makes total sense.
It really does. The isthmus is the narrowest, most proximal portion of the tube leading into the uterine cornea.
Right. Its luminal diameter is incredibly restricted.
And the surrounding muscularis layer lacks the compliance of the ampulla.
So a growing trophoblast is going to erode through the mucosal lining and stretch the serosa of the isthmus to its breaking point much earlier in gestation.
Exactly. And when the isthmus ruptures, it invariably tears through the highly vascular anastomoses between the ovarian and uterine arteries.
Which results in massive acute hemoperitoneum, internal bleeding.
Massive internal bleeding. So the classic clinical presentation you must recognize is a specific triad.
The ectopic triad. Amenorrhea, lower abdominal pain, and abnormal vaginal bleeding.
Yes. But let's analyze the clinical trap associated with risk factors here, because it's a big one.
Okay, yeah. The sources do list significant predisposing factors.
Right. A history of previous ectopic pregnancy, pelvic inflammatory disease leading to tubal ciliary damage, previous tubal surgery.
IVF interventions, or the presence of an IUD.
Exactly. So if a patient presents with this triad and a history of PID, the diagnostic pathway feels obvious.
Right, it clicks. But the danger arises when the patient presents with a completely pristine medical history.
Yes. It is a known cognitive bias in emergency medicine to downgrade the probability of a diagnosis if the classic risk factors are absent.
And the sources provide a statistic designed to just violently break that bias.
Oh yeah. 50% of patients presenting with an ectopic pregnancy possess absolutely zero predisposing risk factors.
50%, half of them.
Half. So you cannot rely on the history to rule this out.
Right. An ectopic pregnancy is the ultimate guilty until proven innocent diagnosis.
Absolutely.
Yeah.
Any female patient of childbearing age presenting with lower abdominal pain and vaginal bleeding has an ectopic pregnancy until your objective diagnostic workup definitively proves the pregnancy is inside the uterus.
And if the diagnosis is delayed and the tube ruptures, the clinical picture degrades rapidly.
Oh, it falls apart. The localized, dull, lower abdominal ache transitions to acute, severe pain.
Right. Physical exam will reveal signs of peritonism, rebound tenderness, and localized guarding, as the free blood chemically irritates the parietal peritoneum.
And a pelvic examination might reveal exquisite tenderness and a palpable fullness in the lateral fornix.
But, and this is a stark warning from the sources, you should not aggressively palpate the adnexa in search of the actual ectopic mass.
No, please don't do that. Aggressive bimanual palpation can inadvertently rupture an intact ectopic pregnancy.
You could literally cause the rupture.
You can instantly convert a stable medical patient into a crashing surgical emergency.
So you evaluate for tenderness, not to outline the dimensions of the mass.
Exactly. Also, the uterus will typically be palpably smaller than expected for the calculated gestational age based on the amenorrhea.
Right. Okay, so management is strictly bifurcated into medical versus surgical pathways.
Yes, depending entirely on the patient's clinical stability and very specific laboratory thresholds.
Right. Medical management utilizes methotrexate.
Right. Methotrexate is a folate antagonist. It competitively inhibits the enzyme dihydrofolate reductase, which ultimately halts DNA synthesis.
So it's exquisitely effective against rapidly dividing cells.
Exactly, which makes it ideal for arresting the proliferation of trophoblastic tissue in an early ectopic pregnancy.
But the inclusion criteria for methotrexate administration are notoriously rigid.
Very rigid. First, the quantitative beta-HCG must be less than 3,500 units per liter.
Okay. And the ectopic mass visualized on transvaginal ultrasound must be less than 3.5 centimeters in its maximum diameter.
Right. These size and hormonal parameters are non-negotiable because they correlate directly with the sheer volume of trophoblastic tissue.
So if the mass is larger or the HCG is higher, the methotrexate will just fail to induce complete resolution.
Exactly. It fails, leaving necrotic, highly vascular tissue in the tube that is highly prone to delayed rupture.
Wow, okay. And the tube must be unruptured, obviously.
Right, and there must be no evidence of fetal cardiac activity on the ultrasound.
Because a beating fetal heart indicates a robust vascular supply and developmental stage that systemic methotrexate just cannot reliably overcome.
Right, the failure rate is unacceptable. Furthermore, the patient must have pristine organ function.
Meaning a normal complete blood count, normal liver function tests, and normal urea and electrolytes.
Yes. Methotrexate is highly nephrotoxic and hepatotoxic, and it induces profound myelosuppression.
So you cannot administer it to a patient with underlying renal or hepatic impairment.
Absolutely not. And there is a critical long-term caveat you must impress upon the patient post-administration.
Right, because methotrexate is highly teratogenic and remains in the system long after the ectopic is resolved.
So the patient must be placed on highly reliable contraception and instructed to strictly avoid pregnancy for a minimum of 3 months.
3 full months. And if the patient violates any of those strict criteria, like if the HCG is 5,000 or the mass is 4 centimeters,
Or if there's a fetal heartbeat, or if they are hemodynamically unstable,
then medical management is entirely off the table.
off the table. You proceed immediately to laparoscopic surgery.
And the surgical options detailed in the sources are a salpingectomy, which is the complete removal of the affected fallopian tube containing the pregnancy, or a salpingostomy.
Right. A salpingostomy involves a linear incision along the antamenteric border of the tube to extract the products of conception, but leaving the tube in situ.
And that decision hinges on the contralateral tube's health and the patient's fertility desires.
Exactly. But the core mandate remains. Unstable patients go to the operating room.
Okay, so once you have definitively ruled out an ectopic pregnancy, your differential shifts from the extrauterine space to the intrauterine space.
Right. The pregnancy is anatomically where it should be, but the bleeding pathology persists.
Which brings us to the second pillar of the big three, miscarriage, or clinically termed spontaneous abortion.
Miscarriage encompasses the spontaneous expulsion of the products of conception before the 24th week of gestation.
And as we established, this drives the vast majority of early pregnancy bleeding presentations.
It does, and the sources outline that approximately 60% of first trimester miscarriages are driven by profound chromosomal abnormalities, predominantly chromosomal trisomies.
60%. So the biological reality is that this is the body's intrinsic quality control mechanism terminating a genetically non-viable sequence.
Exactly, and communicating this clearly to the patient is a vital clinical skill.
It really is, because it alleviates the inevitable crushing guilt they feel.
Right, assuring them that the loss was not triggered by their actions or lifestyle choices.
Yeah. However, miscarriage is a broad umbrella term. The clinical presentation, the inherent risks, and your required interventions vary wildly depending on the specific subtype.
They do. And to navigate this, the sources provide an elegant structural framework based entirely on your physical examination.
Specifically, the status of the external cervical os.
Yes, the external os acts as the mechanical gatekeeper of the uterus.
Right.
Your diagnostic algorithm branches definitively based on whether that os is closed or whether it is dilated to 5 millimeters or greater.
Let's analyze the clinical scenarios where the os remains closed first.
Okay. A closed os presents three distinct diagnostic possibilities.
The threatened miscarriage, the complete miscarriage, and the missed or silent miscarriage.
Exactly. So the threatened miscarriage is the most frequent presentation you will encounter, up to 14 weeks.
The patient presents with mild lower abdominal cramping and transient, usually light vaginal bleeding.
Right. The speculum exam confirms a closed man's. The transvaginal ultrasound reveals a uterus perfectly compatible with the gestational dates.
And crucially, a viable fetal heartbeat is present.
Yes, the bleeding is often a subchorionic hemorrhage blood tracking between the chorion and the uterine wall. But the integrity of the pregnancy remains intact.
So the primary clinical objective here is risk communication and observation.
Exactly. And the sources provide a highly reassuring metric here.
Oh, this is a good one.
Yeah, if the transvaginal ultrasound confirms a normal, viable fetal heart, there is a 90 to 95% probability that the pregnancy will progress normally to term.
90 to 95%, that's huge.
It is. So your management is just expectant observation and reassurance.
Okay, the second closed both scenario represents the end of the physiological process, the complete miscarriage.
Right. In a complete miscarriage, the uterus has successfully and totally evacuated all products of conception.
The heavy vaginal bleeding and severe cramping that characterize the active expulsion phase have ceased.
And the pregnancy symptoms, which were driven by peaking HCG, begin to rapidly regress.
When you visualize the cervix, the os is clamped firmly shut.
Right. And the ultrasound confirms an empty, well-contracted endometrial cavity.
Provided the patient is hemodynamically stable and afebrile, management is entirely expectant, allowing physiological recovery.
Exactly. Now, the third closed os presentation is clinically insidious, the missed miscarriage.
The missed miscarriage. Because the fetus has expired, but the maternal physiological mechanisms have failed to recognize the demise.
Right. The uterus does not initiate contractions, and the os remains tightly closed.
So the patient will not present with the severe cramping or heavy, bright red bleeding typical of an active miscarriage.
No. Instead, the hallmark presentation is a persistent, asymptomatic, dark, brownish vaginal discharge.
Which represents old blood slowly tracking down from the necrotic tissue.
Exactly. The diagnosis is definitively made on transvaginal ultrasound by the profound absence of fetal cardiac activity in a fetus of sufficient crown rump length.
And the danger of a missed miscarriage lies in retention, right?
Yes. Retained necrotic tissue over prolonged periods significantly elevates the risk of severe pelvic infection and systemic consumptive coagulopathies.
So management necessitates active intervention.
Right. Either via medical induction to force cervical dilation and expulsion, or surgical evacuation via dilatation and curettage, a DNC.
Got it. So that covers the closed os algorithm.
Right.
Now, consider the alternative finding on your speculum examination. The cervical os is dilated to 5 millimeters or greater.
An open os. This indicates that the mechanical integrity of the cervix has yielded.
The process of expulsion is actively underway and is functionally irreversible.
Exactly. And this branched into two categories: inevitable miscarriage and incomplete miscarriage.
Okay, the inevitable miscarriage presents with significantly heavier bleeding and far more severe rhythmic abdominal cramping than a threatened miscarriage.
The uterus is actively contracting.
And the defining physical finding is the open os.
Right. The sources note you may even visualize the products of conception descending into the vaginal vault or visibly distending the cervical canal.
The clinical reality is that the gestation cannot be salvaged.
No, it can't. Now, the incomplete miscarriage occurs when the expulsion process is fragmented.
Right. The patient has passed a volume of tissue, but portions of the chorionic villi or fetal pole remain adhered to the myometrium or trapped within the lower uterine segment.
And because the uterus cannot fully contract down to tamponade the bleeding vessels due to that retained mass,
The patient will continue to experience severe, unrelenting cramping and heavy hemorrhage even after passing significant clots.
exactly. And this is the exact pathophysiological setup for the cervical shock we analyzed earlier.
Right, where the retained tissue physically jams within the dilated os, triggering a vagal cascade.
Yes. So management of an incomplete miscarriage with ongoing hemorrhage mandates immediate intervention to clear the endometrial cavity.
Which requires surgical dilatation and curettage or manual vacuum aspiration to remove the retained products and allow the myometrium to achieve hemostasis.
Exactly. But before we close the chapter on miscarriages, the sources highlight one critical outlier that bridges obstetrics and severe infectious disease:
The septic abortion.
the septic abortion. The context for a septic abortion is frequently, though not exclusively, an unsafe or criminal attempt at pregnancy termination.
It is characterized by the introduction of virulent pathogens directly into the highly vascular, immunocompromised environment of the pregnant uterus.
Right. And the infection rapidly ascends, causing profound endometritis, progressing to salpingitis, peritonitis, and culminating in overwhelming systemic septicemia.
Wow. The clinical presentation is unmistakable and aggressive.
Very aggressive. The patient will present with a high fever, typically exceeding 37.8 degrees Celsius, accompanied by severe, diffuse abdominal pain.
And the definitive diagnostic clue during the pelvic examination is the presence of a purulent, foul-smelling vaginal discharge alongside the bleeding.
Yes. The presence of those signs indicates a life-threatening, rapidly cascading systemic infection.
So the protocol is immediate and aggressive.
You obtain endocervical swabs and blood cultures instantly, and you do not wait for culture sensitivities.
Right. You initiate empiric, high-dose, broad-spectrum intravenous antibiotics immediately.
The sources specifically dictate a triple therapy regimen here: gentamicin, ampicillin, and metronidazole.
Triple therapy. And the pharmacology of that is designed to provide absolute wall-to-wall coverage against gram-negative coliforms, gram-positive enterococci, and the severe anaerobic bacteria that thrive in necrotic uterine tissue.
Exactly. Simultaneously, you mandate urgent surgical consultation.
Because the infected necrotic products of conception act as a massive nidus for the bacteria.
Right. Systemic antibiotics alone will fail unless the source is removed.
So emergency surgical curettage is required.
Yes. And in advanced cases of myometrial necrosis, an emergency hysterectomy is the only intervention that will prevent maternal mortality.
Wow. Okay, so we have established the structural catastrophe of an ectopic pregnancy and the developmental failure of a spontaneous miscarriage.
Right.
The final pathology in our big three shifts focus from anatomy and development to profound chromosomal aberration.
Yes. Gestational trophoblastic disease.
Gestational trophoblastic disease. We are focusing specifically on the benign hydatidiform mole, commonly referred to as a molar pregnancy.
Right. The epidemiology provided by the sources reveals a baseline incidence of approximately 1 in 1,500 to 2,000 pregnancies globally.
However, the demographic data highlights significant variations. There is a pronounced spike in incidence among certain Asian populations.
Yeah, Taiwan is specifically cited, with rates soaring as high as 1 in 125 to 200 pregnancies.
That's a huge jump.
It is. Furthermore, the risk profile heavily skews toward the extremes of maternal reproductive age. Women under 20 and over 40 are at substantially higher risk.
Okay, so the pathology of a molar pregnancy is rooted in a fundamental error during fertilization.
Right. In a normal pregnancy, the trophoblastic cells develop into the placenta, establishing the vascular interface to support the growing fetus.
But in a molar pregnancy, due to mechanisms like the fertilization of an empty ovum lacking maternal DNA, or dyspermy.
Which is 2 sperm fertilizing 1 egg.
Right. The chromosomal balance is entirely disrupted.
Entirely. The result is that the fetus fails to develop entirely, or develops with severe lethal anomalies.
However, the trophoblastic tissue, the cellular machinery designed to invade the uterine lining and secure blood flow, proliferates aggressively.
Right, and it's completely unchecked by normal regulatory signals.
Right.
The chorionic villi become highly edematous, swelling into thousands of tiny fluid-filled cysts.
And the clinical presentation reflects this explosive, disorganized cellular growth.
It does. The patient typically presents in the first or second trimester with irregular, heavy vaginal bleeding.
Crucially, unlike the severe cramping of an inevitable miscarriage, the sources note this bleeding is usually painless.
Yes, usually painless. And physical examination reveals a uterus that is drastically large for dates.
Right. A patient at 8 weeks gestation may present with a fundal height corresponding to a 16-week pregnancy.
Because the hyperplastic trophoblastic tissue is expanding exponentially faster than a normal amniotic sac?
The endocrine consequences are equally dramatic. This massive volume of trophoblastic tissue secretes beta-HCG at levels far exceeding a normal singleton or even twin pregnancy.
Astronomical levels of HCG. And these levels cross-react with other endocrine receptors, notably triggering severe intractable nausea and vomiting.
Hyperemesis gravidarum.
Exactly. So when you have a patient presenting with early pregnancy bleeding, a disproportionately massive uterus, and severe hyperemesis.
Gestational trophoblastic disease must be at the forefront of your differential.
Absolutely. The patient may also volunteer a highly specific pathognomonic symptom.
The passage of what the sources describe as vesicles from the vagina.
Right. These are actual clusters of the hydrophic chorionic villi, visually resembling pale grapes being expelled through the cervix.
Like little grapes. The definitive diagnostic modality is the transvaginal ultrasound, though.
Yes. You place the probe, and there is no gestational sac, no fetal pole, and no cardiac activity.
Instead, the endometrial cavity is entirely distended by a chaotic echogenic mass containing thousands of tiny anechoic cystic spaces.
Right. And the physics of the ultrasound waves bouncing off these fluid-filled vesicles generates the classic, highly recognizable snowstorm pattern.
The snowstorm pattern, so the immediate management requires surgical evacuation.
Yes. A dilatation and curettage under general anesthesia is performed to carefully suction the hyperplastic tissue from the uterus, mitigating the significant risk of hemorrhage during the procedure.
But the D&C is merely the initial stabilization, right?
Right. The sources mandate an incredibly rigid, long-term post-operative surveillance protocol.
You must track the patient's serum or urine beta HCG levels every single week.
Every single week. Following a complete evacuation, the HCG curve should display a steady, predictable decline, reaching undetectable baseline levels within 12 to 16 weeks.
And you are obsessively tracking that curve, because if the HCG levels plateau or worse, begin to rise again.
You are observing malignant transformation.
Right. While the initial hydatidiform mole is benign, gestational trophoblastic disease carries the inherent sinister potential to mutate into choriocarcinoma,
which is a highly aggressive, rapidly proliferating gynecological malignancy.
Choriocarcinoma is notorious for its propensity to metastasize hematogenously early in its disease course.
Right, aggressively spreading beyond the uterus to invade the pulmonary vascular bed, the brain parenchyma, and the skeletal system.
And because rising beta HCG is the primary tumor marker for recurrent disease or choriocarcinoma, you must ensure the diagnostic picture remains unclouded.
Exactly. Therefore, the absolute clinical mandate is that the patient must strictly avoid pregnancy for a minimum of 1 full year post-evacuation.
1 full year, you implement highly reliable contraception immediately.
Because if the patient conceives during that surveillance window, the normal physiological surge in HCG from the new pregnancy will perfectly mask the rising HCG of a deadly metastasizing choriocarcinoma.
So a full 1 year unclouded runway is required to confirm the patient is definitively cured.
Exactly.
Okay, so we have meticulously detailed the catastrophic pathologies, the ectopic ruptures, the septic abortions, the molar pregnancies.
The scary stuff.
But your clinical reality will also involve a vast number of presentations where the etiology of the bleeding is entirely benign.
Yes, localized to the lower genital tract and posing zero threat to the pregnancy.
And recognizing these benign entities is crucial to avoid unnecessary interventions and to provide immediate evidence-based reassurance to a highly anxious patient.
Absolutely. The sources highlight 2 specific benign cervical pathologies that frequently present as limited vaginal spotting, particularly postcoital bleeding.
The first is cervical ectropion. The sources identify this as the most frequent cause of postcoital bleeding in young reproductive age women.
Right. To understand the pathology, you must understand the histology of the cervix.
Okay.
The exocervix, the portion visible in the vagina, is lined by robust, stratified, squamous epithelium, built to withstand the mechanical friction of the vaginal vault.
Right, it's tough.
But the endocervical canal is lined by a delicate single layer of mucus-secreting columnar epithelium.
So in a cervical ectropion, the anatomical boundary between these two tissues, the squamocolumnar junction, physically migrates outward.
Yes, that fragile single-layer columnar epithelium protrudes through the external os, exposing itself directly to the vaginal environment.
And when you visualize this on a speculum exam, the exposed columnar tissue appears as a distinct, beefy red ring encircling the external os.
Contrasting sharply with the pale pink squamous tissue.
And because it is highly vascular and structurally fragile, it is incredibly friable.
Exactly. Minor mechanical trauma, such as sexual intercourse, will easily cause capillary disruption and light bleeding.
It is essential to understand that this is not a disease process or a precancerous lesion.
No, it is a physiological response heavily driven by elevated estrogen states.
Like the hyperestrogenic environment of a normal pregnancy perfectly facilitates this eversion of the endocervical tissue.
Yes, it is also highly prevalent in patients utilizing combined oral contraceptive pills,
The tissue will also produce a physiological increase in clear or white mucus discharge.
which crucially differentiates it from the purulent discharge of an infectious cervicitis.
Right. So if your pregnant patient presents with postcoital spotting and the speculum exam reveals an ectropium with no other red flags, the intervention is pure reassurance.
You confirm that the bleeding is external to the pregnancy and poses no risk to the fetus.
The second benign pathology noted in the sources is the cervical polyp.
Right, these are hyperplastic, localized overgrowths of the endocervical epithelium that protrude on a stalk through the os.
Like the ectropion, polyps are highly friable and prone to contact bleeding.
Yes. They're visually obvious on a speculum exam as smooth, red, pedunculated masses.
And similarly require only reassurance regarding the safety of the ongoing pregnancy.
Exactly.
Okay, we have mapped the entire differential, from the big three to the benign outliers. Now, we must synthesize this pathology into a rigid, linear diagnostic algorithm.
Right. How do you definitively prove which process is occurring when the patient is in front of you?
The diagnostic sequence begins with the clinical evaluation, the physical and speculum examination.
Yes. You assess the overall uterine volume through bimanual palpation. You are constantly cross-referencing. Does the physical size correlate with the patient's stated last menstrual period?
Right, a disproportionately small uterus raises the index of suspicion for an ectopic pregnancy or a missed miscarriage.
And a disproportionately massive uterus demands evaluation for gestational trophoblastic disease or multiple gestations.
You assess for localized pelvic tenderness. A critical finding is cervical motion tenderness, classically termed cervical excitation.
Yes. If manipulating the cervix elicits profound pain, it indicates significant inflammation or free blood irritating the pelvic peritoneum.
Which strongly suggests a leaking ectopic pregnancy or severe pelvic inflammatory disease.
Right. Then you proceed to direct visualization via the speculum examination. But the sources mandate a massive, non-negotiable clinical caveat regarding vaginal exams in pregnant patients.
Oh, this is so important. While a speculum examination is an absolute diagnostic requirement for evaluating first trimester bleeding, you must never perform a digital vaginal exam or insert a speculum blindly in a patient presenting with third trimester bleeding.
Never. The risk in the third trimester is placenta previa, where the vascular mass of the placenta overlays the internal cervical os.
Right, digital penetration of the os in that scenario will shear the placental vessels, instantly triggering a massive, potentially fatal maternal and fetal hemorrhage.
You must confirm placental location via ultrasound first in later gestations.
But in the first trimester, the speculum is mandatory.
You use it to directly interrogate the cervical os framework. Is the os definitively closed, placing the patient in the threatened, complete, or missed category?
Is it dilated past 5 millimeters, confirming an inevitable or incomplete process?
Are products of conception actively trapped in the canal? Or are you simply looking at a benign, bleeding cervical ectropion?
Right, so the physical exam maps the anatomy. Next, you deploy the critical diagnostic duo to visualize the invisible. Quantitative beta-HCG serology paired with the transvaginal ultrasound.
Yes, you confirm the presence of beta-HCG with a rapid urine assay. But to drive the algorithm, you require the precise serum quantification.
You need the exact numerical value of the hormone in the peripheral blood.
Right. We correlate this specific number with the ultrasound findings using a core principle called the discriminatory zone.
The discriminatory zone is arguably the highest yield concept in early pregnancy management.
It really is. It is defined as the specific serum beta-HCG threshold at which a high-resolution transvaginal ultrasound must reliably visualize a normal intrauterine gestational sac.
According to our specific sources, that discriminatory threshold is established at a beta-HCG of 1,000 units per liter.
Right. Let's map the clinical logic. If you draw the patient's blood and the HCG returns at 1,500 units per liter, the pregnancy has generated sufficient trophoblastic mass that the gestational sac should be easily visible within the endometrial cavity.
You perform the transvaginal ultrasound. If the HCG is 1,500, but the ultrasound reveals an entirely empty uterus, you have a definitive clinical crisis.
Yes, the pregnancy exists, but it is hiding. And until you surgically or medically prove otherwise, that pregnancy is implanted in the fallopian tube.
That specific combination HCG above the discriminatory zone plus an empty uterus is the diagnostic hallmark of an ectopic pregnancy.
Exactly. Conversely, if the serum HCG returns at 400 units per liter, it falls below the discriminatory zone.
Right. The gestational sac is simply too small to resolve on the ultrasound monitor.
So the algorithm dictates you observe the patient and repeat the quantitative HCG in 48 hours to assess the doubling time.
Which helps differentiate a normal early intrauterine gestation from a failing or ectopic pregnancy.
Exactly. When analyzing the transvaginal ultrasound images, you evaluate specific parameters based on the differential.
Right. For a suspected normal gestation or miscarriage, you measure the mean sac diameter, assess the volume of the amniotic liquor, and crucially, confirm the presence or absence of fetal cardiac activity.
If your differential prioritizes an ectopic pregnancy, you scrutinize the adnexa for a complex tubal mass, or the classic tubal ring sign.
And you evaluate the pouch of Douglas, the rectuterine pouch, for the presence of anechoic free fluid, indicating hemoperitoneum from a leaking tube.
And if the clinical picture suggests a molar pregnancy, you sweep the uterus, searching for the diagnostic echogenic snowstorm pattern of vesicular proliferation.
Okay, so the physical exam, the HCG, and the ultrasound form the diagnostic triad. But the sources isolate one final laboratory requirement that you cannot overlook.
Right. It is a critical error to ignore the patient's hematological profile.
You must ascertain the patient's ABO blood group and, critically, their rhesus D antigen status.
Yes. You are specifically identifying mothers who are rhesus D negative.
Because the pathophysiology here bridges obstetrics and immunology.
It does. During any event that causes early pregnancy bleeding, a miscarriage, an ectopic rupture, or even minor trauma, there is a significant risk of feto-maternal hemorrhage.
Where fetal erythrocytes cross the placental barrier and enter the maternal systemic circulation.
Right. If the mother is rhesus negative, but the fetus inherited a rhesus positive gene from the father, the maternal immune system will encounter those rhesus positive fetal erythrocytes and recognize them as foreign pathogenic antigens.
This triggers a massive immune cascade resulting in alloimmunization.
Yes. The maternal B cells generate permanent, highly targeted IgG antibodies against the rhesus D antigen.
And while this initial sensitization rarely impacts the current failing pregnancy, the immunological memory is permanent.
That's the danger. If this patient conceives a rhesus-positive fetus in any subsequent pregnancy, those preformed IgG antibodies will easily cross the placenta,
Aggressively binding to the fetal erythrocytes and triggering massive fetal hemolysis, leading to profound fetal anemia, hydrops fetalis, and in utero death.
It's devastating. So to intercept this immunological cascade, we utilize a highly effective pharmacological intervention, anti-D immunoglobulin.
Right. By administering anti-D immunoglobulin intramuscularly to the rhesus-negative mother, we essentially flood her circulation with passive antibodies that immediately bind to and mask any circulating fetal rhesus-positive cells.
The maternal immune system never recognizes the antigen, and the permanent alloimmunization sequence is aborted.
Determining the rhesus status and administering anti-D to every single rhesus-negative patient presenting with early pregnancy bleeding is a non-negotiable standard of care.
Absolutely non-negotiable.
Okay, we have systematically dismantled the pathology of early pregnancy bleeding. To cement this framework for your clinical practice, let's synthesize the high-yield, actionable takeaways.
Good idea.
Yeah.
First and foremost, the triage mindset governs all actions. Always evaluate and stabilize maternal hemodynamics, the ABCs, before initiating a nuanced diagnostic workup.
Right. Be highly vigilant for the profound bradycardia and hypotension of cervical shock, and recognize that the immediate life-saving intervention is the mechanical removal of tissue from the cervical os.
Second, ectopic pregnancy is the apex can't-miss diagnosis. Memorize the triad of lower abdominal pain, abnormal bleeding, and amenorrhea.
And burn the statistic into your mind that 50% of these patients will present with absolutely no predisposing risk factors, rendering a clean history irrelevant.
Third, rely heavily on the cervical os framework to categorize miscarriages. A closed os narrows the differential to a threatened, complete, or missed miscarriage.
While dilation of the os past 5 millimeters signifies an irreversible process, categorizing it as an inevitable or incomplete miscarriage.
Fourth, maintain a high index of suspicion for gestational trophoblastic disease, the molar pregnancy. The clinical hallmarks are the snowstorm pattern on ultrasound, severe hyperemesis secondary to astronomical HCG levels, and a uterus disproportionately large for dates.
The rigid weekly HCG follow-up is mandatory to intercept malignant transformation into choriocarcinoma.
And fifth, unequivocally confirm the rhesus status of every bleeding patient and administer anti-D immunoglobulin to all rhesus-negative mothers to prevent catastrophic alloimmunization in future pregnancies.
That structural framework will guide you through the chaos of the emergency department. But before we conclude, the sources offer a final, compelling clinical detail that shifts our perspective entirely.
Yeah, this is a fascinating point.
Throughout this analysis, we have focused on genetic anomalies, hormonal derangements, and severe infectious cascades. But occasionally, the pathology is stripped of all microscopic complexity and is purely mechanical.
Right. The sources briefly highlight a phenomenon termed cervical incompetence. This pathology typically manifests later, in the second trimester, around the 16-week mark.
Unlike the severe rhythmic cramping of an inevitable miscarriage, cervical incompetence presents as a completely silent, painless dilation of the cervix.
The structural integrity of the cervical connective tissue simply yields. As the intrauterine pregnancy grows, the increasing gravitational weight and hydrostatic pressure of the amniotic sac silently force the internal os open.
Until the membranes ultimately rupture and the pregnancy is lost. It is a devastating mechanism for recurrent mid-trimester loss.
However, the intervention for this structural failure is remarkably devoid of complex pharmacology. It is an intervention based entirely on fundamental surgical engineering.
The procedure is the cervical cerclage. If a patient is identified with a history of cervical incompetence, an obstetric surgeon will intervene prophylactically at 12 to 14 weeks gestation.
They utilize a heavy, non-absorbable suture to physically encircle the cervix, tying the os tightly shut like a heavy drawstring bag.
And the clinical efficacy of this simple mechanical reinforcement is staggering. The sources note that this physical suture rescues 80% of these compromised pregnancies, successfully maintaining structural integrity until term delivery.
It is a profound reminder that amidst the intricate endocrinology and immunology of obstetrics, occasionally the most effective medical intervention is basic structural mechanics.
You just have to ensure the surgical team remembers to cut the mechanical suture before the physiological forces of labor begin.
Yes, an absolutely vital detail for delivery.
When you step onto the floor for your next shift and the telemetry alarms are sounding at 2 a.m., you possess the algorithm. You are no longer navigating diagnostic muddy waters.
You understand the physiological why behind the clinical what.
Apply this framework, protect maternal hemodynamics, interrogate the discriminatory zone, and you will navigate these emergencies with absolute clinical precision.